Welcome to COVID Thrombosis and the Research, Steering into the Storm with Full Sails, a medical education program brought to you by the North American Thrombosis Forum. This program will address the unique cardiovascular risks and challenges that patients face when recovering from COVID-19, with a particular focus on thrombotic illnesses. The epidemiology, pathophysiology, and prevention of CV complications in COVID-19 will be discussed, and the program will conclude with a case series exploring key clinical dilemmas in COVID-19 associated thrombosis. Dr. Samuel Goldhaber will start us off with a public health challenge, the burden of venous and arterial thrombosis in COVID-19. Dr. Galit Friedman will then discuss the mechanisms and histopathology of thrombosis in COVID-19. Dr. Gregory Piazza will talk about recognizing the hazard of cardiovascular complications in COVID-19. Dr. Alex Baropoulos will address thrombosis prevention in COVID-19 and help us navigate the current trial data and guidance documents that are available. And Dr. Binood Bigdeli will take us home with a case series focusing on clinical dilemmas in patients with COVID-19 and thrombosis. The case series will cover both inpatient and outpatient situations.
Hello, I'm Dr. Sam Goldhaber, President of NATF, and I am the Associate Chief and Clinical Director of the Division of Cardiovascular Medicine at Brigham and Women's Hospital. I'm also Professor of Medicine at Harvard Medical School, and I'm going to speak with you about COVID-19 and the burden of thrombosis. Here are my disclosures. And we're going to try to cover quite a few topics in a short period of time. We'll go back to the Spanish flu, then discuss COVID-19 symptoms, cardiac injury, autopsy findings, talk about venous thromboembolism, arterial thromboembolism, and major adverse cardiovascular events. Then we'll discuss the post-COVID syndrome, sometimes called the long hauler syndrome, patients who recover from the infection of the virus but remain debilitated. So it seems like something bad happens about once every 100 years. In 1720, it was the plague. In 1820, cholera. In 1920, the Spanish flu. And in 2020, the coronavirus. This is what the virus of the Spanish flu looks like. And here we have photos from 100 years ago. You see these ladies dressed rather formally, outdoors in the fresh air, wearing masks. And I learned that next to my hospital, Brigham and Women's Hospital, is the town of Brookline. And on the Brookline-Boston border, there were so many patients that no hospital had enough bed capacity. So tent hospitals were set up. Here you see a photograph from San Francisco, a very well-dressed businessman being stopped by a police officer. The businessman is called a masked slacker because he is defying the law to use masks, even though the Spanish flu pandemic really crippled and seized in 1918 the city of San Francisco. So looking back, I think it's fair to say that the only thing we learn from history is that we learn nothing from history, and history is repeating itself. Here's the coronavirus. It has similar structural characteristics to the Spanish flu virus. Both of them look kind of scary. Well, what are the risk factors and mechanisms for COVID? On the left, we have the risk factors. They're very common: increasing age, obesity, being bedridden, cigarette smoking, pregnancy, and the male gender. On the right, we see the mechanisms, and these include complications from other comorbidities, such as previously existing heart or lung disease, inflammation due to the virus, which causes acute respiratory distress syndrome and COVID pneumonia, cytokine storm, which is an inflammatory response, which the body is putting up a defense mechanism, but its defense mechanism also paradoxically causes damage. Direct lung injury from COVID pneumonia. It seems that hormone use, estrogens, can be a contributory factor. And also, if one is admitted to the intensive care unit, the prognosis is not very good compared to either being able to stay out of the hospital altogether or being able to be hospitalized in a step-down unit. I'd like to tell you my first personal experience with COVID pneumonia was with an 82-year-old retired Boston police detective. He lived by himself. His son was a physician and had 24-hour help for dad, but it turned out that one of the helpers had a roommate, and that roommate had COVID, and the helper for dad developed COVID. And after my patient went to the primary care doc, at first was thought to have a community-acquired pneumonia and given a Z-Pak, but didn't improve. He was hospitalized at one of our sister hospitals with typical COVID pneumonia findings. At first, he seemed stable. 82 years old, he had had heart attacks, he had coronary stents, peripheral vascular disease. I always thought that his ultimate demise would be cardiovascular. But over 24 hours, very quickly, this happened in deterioration really in 6 hours, he starts to develop whiteout of his lungs and much worse pneumonia and lung injury. And he ultimately succumbed to COVID. So what are the mechanisms of cardiac injury with COVID-19? There can be direct myocardial injury, or there can be hyperinflammation, where the inflammatory substances actually cause myocardial injury. And then having a depletion of oxygen and respiratory failure can also damage the heart. You can see elevations of biomarkers of injury, such as troponin levels, being raised. There can be cardiac rhythm disturbances. There can be acute coronary syndromes with myocardial infarction. And then there can be heart failure, either with a preserved ejection fraction or a reduced ejection fraction. Now, what is the time course of COVID-19? In stage 1, the first 5 days, the early infection, patients usually don't have any symptoms. The virus invades the lymphocytes. Those are particular types of white blood cells, and the lymphocyte count goes down. And then around day 5, the patients start to become symptomatic, and they can develop fever and cough and other signs of pulmonary congestion, and their X-ray becomes abnormal with that fluffy type of pneumonia. And then at around 10 days, you see the host response with elevated inflammatory and cardiac biomarkers. The stage 3 is called hyperinflammation. At autopsy, here are the lungs of a patient who expired due to COVID. They're filled with edema. They're twice as heavy as they should be. And here you look a little more closely at the lungs of the same patient, and you see that there are micro thrombi scattered throughout the lungs. These are in the pulmonary vessels. These are micro pulmonary emboli. We don't think that these types of pulmonary emboli originate in the leg veins and then break off from the leg veins and go traveling into the lungs. We think these are formed at the site of the pulmonary vessels directly. And here you see the heart. This is the right ventricle and the left ventricle. This right ventricle is dilated and much bigger than the left ventricle. Very abnormal, but a common finding in patients who've had a serious pulmonary embolism. And here you see three different hearts. All of them are showing right ventricular enlargement compared with the left ventricle. Here, at these blue arrowheads, you can see the virus within the lung cells. And here you see the virus within the renal tubular epithelium. The thrombosis can be venous or arterial. Here you see arterial thrombosis of the brain with infarction causing stroke and hemorrhage surrounding the infarction. Here you see a microthrombus from the brain. Here's a microthrombus within the heart. And here is a microthrombus in the portal vein, a venule, really tiny vein. So you see the thrombosis can occur almost anywhere within the body, though the most common target happens to be the lungs. Now, Corona VTE is an observational study that our thrombosis research group initiated. It's a dynamic retrospective and prospective observational cohort study across the Mass General Brigham or MGB network. To find the patients, we use a silent, updatable EPIC Best Practices Advisory or BPA to identify every COVID-19 positive patient within our network. Our network includes Brigham and Women's Hospital, Mass General Hospital, and 8 to 10 smaller hospitals, community hospitals such as the Faulkner Hospital or Martha's Vineyard Hospital, plus a scattering of outpatient clinics in eastern Massachusetts. The outcomes of the registry include 30-day venous thromboembolism, stroke, myocardial infarction, myocarditis, heart failure, arrhythmia, and death. And these outcomes are adjudicated by a clinical endpoint committee. Now we have accrued more than 2,000 patients with complete 30-day follow-up. And we published our results in the first 1,100 COVID-19 patients in this Corona VTE cohort. And we focused on the subset of patients, the minority of patients who required hospitalization in the ICU, the intensive care unit. And what we found in the ICU was very disturbing. Symptomatic arterial or venous thromboembolism was present in 36% of the patients. Major adverse cardiac events such as heart attack, stroke, or cardiovascular death occurred in 47%. And symptomatic pulmonary embolism or symptomatic DVT occurred in 27% of these ICU patients, even though almost all of them received venous thromboembolism prophylaxis with either low molecular weight heparin or with mini-dose heparin. Well, we tried to figure out what might predispose a patient to have one of these adverse cardiac events or thrombosis in the population. And really, I wanted to point out that the venous thromboembolism prophylaxis, this would be a low dose of enoxaparin, for example, or 5,000 units of unfractionated heparin 3 times daily, had no effect at all. With respect to acute respiratory distress syndrome, which occurs commonly with COVID pneumonia, multivariate analysis shows a more than 6-fold likelihood of these patients developing an adverse event in the ICU. And we also found that there was a 17% increased chance of an adverse event if the patient had a blood test, the D-dimer, a global test of coagulation, that was elevated. Now, what happens over the first several years? Well, we don't know. COVID-19 has only been with us for 11 or 12 months. But we do think that after the acute phase, there's a convalescent phase. And perhaps during this convalescent phase, we can speculate that there's the development of inflammation of the heart muscle, myocarditis, or cardiac arrest with sudden cardiac death. And in the chronic phase, again, we don't know for sure what happens over the next few years, but we can speculate perhaps the lipid levels increase, or perhaps there is development of pulmonary fibrosis due to the prior injury of COVID pneumonia. Now, the post-COVID syndrome is becoming increasingly recognized as a long-term problem, sort of like chronic Lyme disease, but perhaps worse. These patients are sometimes called COVID long haulers. And here's a sample of 143 patients who were written up. Their mean age was 56 years. 37% were women, and they were assessed on average 60 days after the first COVID symptoms. 13% were asymptomatic, but the others had persistent fatigue, half of them, persistent shortness of breath, almost half of them, and then joint pain and chest pain were also common chronic complaints. And we really haven't figured out how best to manage the post-COVID syndrome. We do know that the post-COVID syndrome has the same major symptoms as the acute COVID-19 phase: fatigue, dyspnea, difficulty breathing, joint pain, chest pain, and cough. The frequency is diminished, but the symptomatology is very similar. So the take-home points: inflammation and cytokine storm in acute respiratory distress syndrome patients with COVID-19 pneumonia precipitate pulmonary embolism, deep vein thrombosis, and myocardial infarction. Ethnic and racial minorities suffer disproportionately from COVID-19 and its thrombotic complications. This might be because socioeconomically their housing is more cramped and it's harder to social distance, but we really don't understand entirely why this is. We predict that post-COVID syndrome will become more frequent. And in closing, COVID-19 has a profound effect on daily life with psychological, economic, and social disruption of almost unprecedented extent. Thank you very much.
Hello, my name is Dr. Galit Friedman, and I will be speaking to you about mechanisms and histopathology of thrombosis in COVID-19. I currently hold appointments in the Division of Trauma, Emergency Surgery, and Surgical Critical Care at MGH, as well as in the Center for Biomedical Engineering at MIT. In terms of disclosures, just one: I'm the president and CFO of a point-of-care coagulation diagnostics company. In this presentation, we're going to go through 4 major topics. The first one is going to be a review of the path findings on coagulopathies occurring frequently in patients with COVID-19. Now, there are many potential mechanisms for respiratory distress in patients with COVID-19, and likely it is multifactorial, so it's not just going to be one pathological process going on at a time. Some of these findings include hypoxia-induced inflammation, fibrin deposits and increased secretions obstructing the airways, microthrombi in alveolar capillary beds, macrothrombi in larger pulmonary vessels, as well as evidence of alveolar cell stress and death secondary to viral infection, therefore leading in increased inflammation and activation of coagulation. Postmortem findings of patients with severe COVID-19 disease have also identified multi-organ pathology, and this includes both macroscopic and microscopic abnormalities. Some examples include pulmonary thromboembolisms, platelet-rich thrombi in the medium-sized vessels surrounding the heart, glomerular microaneurysms and microthrombi within glomerular capillary loops, as well as splenic, hepatic, and adrenal infections. And this is not a complete list. One other area I thought would be important to talk about is placental pathology. So these studies are ongoing, and it's not a very large number of patients, but there is a study that found fetal vascular malperfusion and fetal vascular thrombosis in about 50% of placentas evaluated post-birth. In these cases, they did not find association with gross umbilical cord abnormalities, and the lesions were considered low grade. All of the infants tested in that study were also negative for the virus. Infection of the placenta itself is found to be rare and doesn't seem to be correlated to the specific histopathology changes. So it does appear that the placenta at this point in time is a pretty good protective barrier for the fetus. Now, the next thing I want to talk about is how coagulation and inflammation are intertwined, because I think a lot of people talk about coagulation abnormalities or inflammation abnormalities, and we really have to keep in mind that this goes hand in hand. For coagulation and inflammation, the best way to think about it really is a chicken or egg phenomenon. So coagulation will activate inflammation and is a critical part of the inflammatory pathway. It'll protect the body, but at the same time, if you get overactivation, it can be detrimental. And inflammation also does the same thing, where it activates coagulation. So you have this positive feedback loop going on. Now, COVID-19 infection, especially the severe disease form, has been correlated with severe inflammation. So you have an increase in inflammatory biomarkers that have been identified. This includes IL-2, IL-6, IL-8, IL-10, TNF-alpha, CRP, a few others, D-dimer, and also increase in SOFA scores for these patients. Now, in terms of talking about cytokine storm and its role with coagulopathy development in these patients, again, I would emphasize this chicken or egg phenomenon. Cytokine storms frequently result in the development of pathological blood clots. And there have been studies even with other viruses such as influenza A showing that there is an uncontrolled coagulation system activation, including both cellular and protein components, which is very intertwined with things like complement pathway and endothelial damage. In terms of what are the mechanisms of thrombosis in COVID-19 patients, they are multifactorial, and I'm going to show a few studies that have been published recently. So the early studies looking at COVID-19 related coagulopathy showed a tendency towards a prothrombotic state. This include measurements of some basic coagulation parameters, so things like significant increase in D-dimer in patients with significant COVID-19 disease, increase in FDPs, fibrinogen. Interestingly, slight prolongation in PT and PTT. So although these patients appear to be in a prothrombotic state, they did have some prolongation in those traditional coagulation times, high SOFA scores, and even in some patients, the detection of anti-cardiolipin and anti-beta-2 glycoprotein antibodies. Now, as COVID-19 has spread through multiple countries, these studies have confirmed the presence of coagulopathies in many of these patients. And this recent study here, which was published out of MGH in Harvard, have evaluated the factor levels within COVID-19 patients, correlating them with the development of pathological clots. Specifically, factor V activity was seen to be significantly elevated and appeared to be correlated with the development of DVT, PE, and appeared to be correlated with SARS-CoV-2 load, which is very interesting. They saw a decrease in factor V was linked to progression towards a DIC state and linked to higher mortality. And other changes in coagulation factors included increases in factor VIII, fibrinogen, and D-dimer as well. There are other studies proposing and identifying the presence of a thrombotic microangiopathy state, so a TMA. This proposed model includes significant involvement from the complement system in the activation of inflammation and coagulation, invasion of pathogen into the endothelial cells would trigger a rapid innate immune response, and prolonged presence of the virus results in increased complement-initiated damage to the vessels, increase in cytokines, and a prothrombotic state. Now, we know that there is evidence of significant endothelial damage in patients with severe COVID-19, and that is linked to changes in coagulation. So you get infection in both the pulmonary epithelial and endothelial cells. The vascular endothelium, we have to keep in mind it is an active organ. And this results in recruitment of immune cells via direct and indirect mechanisms, resulting in widespread endothelial dysfunction associated with cell death and apoptosis. Severe endothelial injury was also found to occur with the presence of intracellular virus and also alveolar capillary microthrombi and increased new vessel growth. Now, we shouldn't forget about the role of platelets as well. So some studies have shown that platelets in patients with severe COVID-19 exhibit a unique phenotype. We don't know at this time whether this occurs at the platelet or the parent megakaryocyte level. Platelets have also been found to be associated with SARS-CoV-2 RNA. Now, they have not shown infection of megakaryocytes or platelets, but association of the RNA with the platelets in circulation. We've also interestingly seen that thrombocytosis is commonly seen in some patients with COVID-19. So whereas many patients, when you think of severe inflammation and coagulopathy and DIC, the most common finding is thrombocytopenia, in many COVID patients, you'll see a thrombocytosis followed by a thrombocytopenia if the patient progresses from that severe prothrombotic state into a DIC state. It is thought to partially be due to increased levels of IL-6, which can increase platelet count. And we already mentioned that thrombocytopenia will tend to occur when the patient switches towards that DIC phenotype. Now, we can't forget to talk about fibrinolysis. There are multiple studies looking at this now, and they've seen evidence of fibrinolysis activation and also dysregulation, such as increases in D-dimer and plasmin. Viscoelastic testing has been very interesting and essentially shows a lack of fibrinolysis. The question here is it a shutdown of the fibrinolysis pathway, or is the patient in such a prothrombotic state that they cannot compensate with a normal or increased activity fibrinolytic pathway? Likely what's happening is that the patient is in both a hyperthrombotic and a hyperfibrinolytic state simultaneously, and that prothrombotic state just can't be overcome with the patient's fibrinolytic mechanisms at that time. Now, in terms of positive acute phase proteins, we have to keep in mind that many acute phase proteins are also coagulation related. So for example, increase in fibrinogen. Fibrinogen is a positive acute phase protein, and this increase can result in stronger and larger clot formation and is itself pro-inflammatory. Other acute phase proteins include increases in factor VIII, increase in endogenous heparinases, and decrease in antithrombin 3. And all of these can contribute to a prothrombotic phenotype and even some level of anticoagulation resistance. And the last potential mechanism that we'll go through in this presentation is the formation of autoantibodies. So there have been studies showing that a cohort of COVID-19 patients do appear to develop different lupus autoantibodies. And more recent mechanistic studies have actually shown overlapping B cell pathways between lupus patients and COVID-19 patients. There are no studies yet demonstrating whether the development of these autoantibodies are transient in nature versus long-term. And the question is the development of these antibodies part of just systemic inflammation and it goes away when the patient gets better? Or are these potentially cross-reactive antibodies where the antibodies are cross-reactive between an epitope on the virus and also against self? So for all of this, coagulation tests are a very important tool. And the last thing that we will go through is just really keeping in mind that coagulation status is dynamic. I like to think about it in terms of the stages of a fire. So you have the ignition and then the fire growth, the fully developed fire, and then you get a decay at the end. So we keep in mind that for COVID-19, severe symptoms typically start around 8+ a day of the disease. This is an average. And this is an opportunity for a small level of inflammation and coagulation over that week or so to increase to a dangerous level. And I want to emphasize the importance of early diagnosis and intervention in these patients. The other thing to keep in mind is that most of the comorbidities that end up placing patients in the high-risk category for severe COVID-19 disease are also known to result in increased levels of inflammation and coagulation activation themselves. And that includes obesity, diabetes, cardiovascular disease, and multiple pulmonary conditions. Many of these patients may already be on antithrombotics, or they may be candidates for antithrombotic therapy even prior to SARS-CoV-2 infection and just not be on them yet. Now, with these pre-existing conditions and outcomes, we have to think about the patient's pre-existing conditions and comorbidities as kind of priming the environment for an exponential increase of inflammation and coagulation, as well as long-term fibrosis in those patients. And this has implications for both acute and chronic care. And we can't forget that genotype and phenotype of patients likely also play a role in their response to SARS-CoV-2 infection, either directly or indirectly. So as an example here on the left is a pathway emphasizing some of the differences in factor levels in the African American population, showing that there is an increased tendency to be in a prothrombotic state compared to counterparts. The other thing to keep in mind is access to healthcare and adequate treatment and management of health conditions. And that likely also plays a role in disease severity. So for example, a patient that is a candidate for anticoagulation therapy even prior to COVID-19 disease, would that potentially make them even more likely to be in that prothrombotic phase and develop that large fire? In terms of anticoagulation, and I'm not going to go through specific therapeutic recommendations, but I do think it's important to emphasize it's likely not one dose fits all. Anticoagulants can serve multiple roles in the treatment of COVID-19, including anticoagulation itself, reduction in inflammation, improvement of cardiac function, reduction in fibrosis, and potentially even have some antiviral properties. Of course, there are risks associated with anticoagulation therapy, and dosing likely needs to be personalized. You have to keep in mind that the coagulation state in these patients is dynamic. So a patient may need an anticoagulant at the beginning in that prothrombotic state. They may become resistant to specific anticoagulants or doses once they become more severe. And if they progress to the DIC state, then that's a completely different treatment paradigm. So the key takeaways from this talk: COVID-19 disease is associated with a prothrombotic state. Inflammation and coagulation go hand in hand. So successful treatment of COVID-19 disease will likely include a combination of anti-inflammatory and anticoagulant medications. So for example, we may find that heparin or platelet inhibitors in combination with complement inhibitors or interferon drugs will be helpful. The disease is dynamic and treatment should be tailored to the patient's stage of inflammation and coagulation. And there's definitely room to be proactive in patients that are at high risk for severe COVID-19 disease. Here are my references, and thank you.
I'm going to be talking to you about recognizing the hazard of cardiovascular complications in COVID-19. I'm Greg Piazza, one of the vascular medicine cardiologists at Brigham and Women's Hospital and the education chair for the North American Thrombosis Forum. Here are my disclosures. And what I'd like to do over the next few minutes is cover the sort of depth and breadth of the cardiovascular complications of COVID-19. COVID-19 has been associated with complications including heart attacks, strokes, and venous thromboembolism. It's thought that a combination of systemic inflammation injury to the endothelium or lining of the blood vessels, immobility, and an overall hypercoagulable state are thought to promote thrombosis, especially in patients with COVID-19 who end up in the ICU setting. Really kind of quantifying the risk of cardiovascular complications in this very heterogeneous population of patients with COVID-19 has been a challenge, and it's limited by small numbers of patients, restriction of the focus and most of the research to the ICU setting, variability in the way that different investigators defined outcomes, and different practice patterns for providing protective anticoagulation for patients with COVID-19. Here we can see the different pathophysiologic mechanisms for cardiovascular disease and COVID-19. You can see that the left-hand panel is incredibly busy. You can look at that by pausing the video and blowing up that portion of the screen. But really what we're looking at is the SARS-CoV-2 virus has the ability to interact with so many different components in our body of our thrombotic preventive system, but also our anti-inflammatory system, and it leads to blood clots and very, very striking inflammation. We can see in the right-hand panel, the COVID-19 leads to severe hypoxemia, very low oxygen saturation. You can get secondary infections from bacteria that can grow in the midst of all of this inflammation. That can lead to sepsis. There's a very strong systemic inflammatory response to this virus, more so than we might see with other viruses that can have cardiovascular complications. We can develop clots in our lungs, pulmonary embolism. And overall, there's just an incredible stress response to SARS-CoV-2, and that can lead to decreased cardiovascular health, decreased cardiac function, and inflammation, and sometimes even viral infection to the heart muscle. All of these things can lead to signs of our cardiovascular system being irritated, which we can sometimes measure in the form of something called a cardiac troponin. The thrombosis risk in COVID-19 has been shown since the start of the pandemic. This study actually was very nice out of Italy, looking at almost 400 patients hospitalized with COVID-19. Almost 100% of patients got thromboprophylaxis, so some type of anticoagulant to help prevent against blood clots. And in this setting, arterial and venous thromboembolic events occurred in 16.7% of the ICU patients and 6.4% of patients who were hospitalized but weren't sick enough to be in the ICU. In its overall cohort, they saw venous blood clots, ischemic strokes, and heart attacks in 4.4%, 2.5% and 1.1% of patients respectively. So higher numbers than we're used to seeing in our ICU patient populations, at least for the combination of these different thrombotic complications. One question that came up very early actually in the pandemic is this thrombotic risk specific to COVID-19, or if you had some other very severe infectious illness, could that cause the same type of strong prothrombotic response? Really, we don't have a definitive answer, although this study from Roberts is very interesting because it suggests that perhaps it's not specifically COVID-19, but the fact that COVID-19 makes patients so sick that explains this high burden of thrombosis. So in this UK study of almost 2,000 hospital discharges for COVID-19 and almost 20,000 hospital discharges for non-COVID-19 medical disease, they observed kind of similar rates for hospital-associated venous thrombosis. And when they did a special type of multivariate analysis, they found that COVID-19 itself as a virus probably didn't predict the risk of VTE. It was probably more related to the severity of illness that we see with COVID-19. And if you were to get the flu or some bacterial illness that made you similarly acutely ill, you'd probably see the same type of VTE rate. Very interesting study. Early on in the pandemic, there were a lot of reports that suggested that the conventional thromboprophylactic regimens, the usual medications that we give to our patients to prevent thrombosis, were ineffective. There were some studies that showed that the incidence of arterial and venous thrombosis adjusted for the competing risk of death was up to 50%. So almost 50%, almost half of patients having thrombotic complications, despite all of them receiving a low molecular weight heparin-based prophylactic regimen. They also, in this study, suggested that if you were on full dose anticoagulation, so not prophylactic dose, but if you were given anticoagulation that we normally would provide to patients who had known blood clots, there was a reduction in the risk of blood clotting. So this actually got a lot of investigators interested in looking at giving patients therapeutic anticoagulation for prevention. So high levels of anticoagulation, not to treat blood clots, but to prevent them, because the thinking is that the risk of blood clotting is so high that you need more than just the prophylactic doses. Another big question in the midst of the pandemic was so many of these studies focused on ICU patients. What about patients who are in the hospital but not in the ICU? This was a study of 84 non-ICU patients hospitalized with COVID-19, and the risk wasn't nearly as high as we saw in the ICU. All of these patients got thromboprophylaxis, and the risk ended up being about 12%. And further studies have suggested that it's probably somewhere between the 5 to 10% range, including American-based studies. When we see patients really sick with thrombotic complications, it's typically pulmonary embolism, especially in the ICU. And one of the factors that has come up for a predictor of ICU patients with COVID-19 developing pulmonary embolism are these shown here. Having a body mass index of over 30, so being obese, having a blood test that shows that the coagulation system is activated, that's called a D-dimer. There's some suggestion that statins may help to prevent thrombotic complications, so there's an inverse correlation where statins might be protective, and there are nice studies looking at this as a potential way to prevent blood clots. We've also noticed in patients with COVID-19 an increased rate of heart attacks and myocardial necrosis. And if we look at patients who are sick in the hospital with COVID-19, if there's increase of this blood test that corresponds with myocardial or heart muscle necrosis, that corresponds with a poor survival. And that's actually been shown in a number of studies, and we can see here that survival is worse if that troponin, that cardiac troponin, is increased. Patients who have underlying cardiovascular disease, so patients who've had heart attacks before their diagnosis of COVID-19 or have heart failure, seem to have a higher risk of adverse outcomes in patients with COVID-19. We see that here. The risk of in-hospital mortality is higher if patients had previous cardiovascular disease. Here, we can see that in patients who have signs of these increased cardiovascular blood tests, these markers of cardiac injury like troponins, in-hospital mortality is also increased. This is a very busy table, but essentially it's a study looking at over 3,000 patients hospitalized with COVID-19 in a New York hospital system. And what we can see here is a graded risk, where the risk of developing venous thrombosis or other types of thrombosis is highest in the ICU setting, then a little bit less in the non-ICU patient cohort. And that's important. That gradation of risk is important because we're going to concentrate a lot of our aggressive protective therapies in the ICU patients and maybe less so for the non-ICU hospitalized patients. We did a study called Corona VTE, which included patients from across the Mass General Brigham entity. And we were able to show a similar finding that the risk is really highest in patients who are in the intensive care system, and then in the non-intensive care system, but hospitalized, it's a little bit less. A lot of the intensive care patients had COVID pneumonia, ARDS, were on mechanical ventilation, or had sepsis. And those are important risk factors, all of them, for thrombotic outcomes. We can see here that in the intensive care setting, about 35% of patients had major arterial or venous thromboembolic events, and about 3% of patients had those types of complications who were not in the ICU but hospitalized. So really, that gradation of risk is very strong. We can see here that the risk seems to be highest sometime after 5 days. After 5 days, that's when we start to see these major arterial and venous thromboembolic complications in hospitalized patients. And that's probably when we start to see either complications of the COVID-19 infection or worsening in the patient's clinical status. So that's probably why that 5-day mark seems to hold true. We see that in major cardiovascular events as well. It's around 5 days where we really start to see a number of patients develop an increased risk of these cardiovascular events. And same thing with systemic venous thromboembolism. Patients who are in the ICU especially and stay in the ICU around 5 days start to develop a lot of complications, and that may be something that we need to keep an eye on for protecting these patients. We found that the development of ARDS, which can be seen around that 5-day window, really corresponded with a high risk of arterial or venous thromboembolic events, almost a 7-fold increased risk. In cardiovascular events, almost a 6-fold increased risk with ARDS, that acute respiratory distress syndrome, almost a 24-fold increased risk if patients had ARDS. So really something for us to keep in mind. I mentioned briefly that the COVID-19 can actually affect directly the heart muscle, and we see that here. Patients can develop inflammation of the heart muscle. We call that myocarditis. And if you do an MRI on these patients, you can actually see this highlight here, this white strip here. That's something called late gadolinium enhancement. And that's actually direct inflammation and possibly infection of that part of the heart muscle that keeps it from contracting well and can lead to heart failure. So this is a more recently described and very important complication of COVID-19. So to summarize, cardiovascular events, including myocardial infarction, stroke, and pulmonary embolism, are really important complications of COVID-19. They contribute to this overall burden of risk and even mortality after the infection. Further research is going to be really important in a number of arenas, defining the risk of non-thrombotic complications like arrhythmia, cardiomyopathy, and myocarditis, but also in figuring out the best way to prevent these cardiovascular complications. How do we reduce morbidity? How do we reduce mortality in COVID-19? Specifically, what regimens of antithrombotic and anticoagulant therapy are needed to protect our patients in the ICUs, in the hospital, and even some high-risk patients who are home recovering. And so plenty for us to think about as we keep fighting this pandemic. Thank you very much.
Hello, my name is Alex Veropoulos, and I will be discussing the clinical trials and guidance documents with respect to preventing thrombosis, specifically in hospitalized COVID-19 patients, but also in pre- and post-hospital settings. These are my disclosures. And in terms of an overview, I think we can all appreciate the devastating implications of COVID-19 caused by the SARS-CoV-2 virus. In the United States alone, over 24 million cases and counting, and now approaching 500,000 deaths. Thrombotic complications have been associated with up to 60% of deaths, especially in patients with underlying cardiovascular disease. And autopsy series reveal a high incidence of unsuspected venous thromboembolism, or VTE, in these patients. Now, in the pre-COVID era, hospitalized medical patients, including those with pneumonia and sepsis, have been described as moderate to high risk of VTE. And we can expect anywhere from a 50 to 60% risk reduction with the use of in-hospital thromboprophylaxis. In addition, there remains a subset, about 25% of medically ill patients, that are at high VT risk to benefit from a strategy of extended post-hospital discharge thromboprophylaxis, usually with a direct oral anticoagulant or DOAC. And lastly, previous experience with viral pneumonias, especially in the setting of acute respiratory distress syndrome or ARDS, have shown a multifold increased risk for VTE, with a significant reduction of that risk using empiric therapeutic dose anticoagulants. Now, the coagulopathy of COVID-19 is quite complex, involving multiple players with respect to both generation of a cytokine storm and this fairly newly described phenomenon of thromboinflammation. Entry of the SARS-CoV-2 virus into alveolar tissue produces an inflammatory response with subsequent cytokine storm, complement activation, again, a large inflammatory response, and importantly, endothelial cell activation and subsequent dysfunction. There's also evidence of contact system activation, ultimately leading to thrombin generation and hypercoagulability. Now, the risk factors for thrombosis in COVID-19 include both classic patient-related risk factors such as advanced age, immobility, the presence of underlying cardiopulmonary disease, and cancer, but also very viral-specific factors, especially due to the inflammatory response and endothelial dysfunction of superinfected individuals. There's evidence of a decrease in tissue factor pathway inhibitor, lymphopenia, and importantly, a marked inflammatory cytokine response, especially with interleukin-6. Multiple hemostatic abnormalities have been described, including evidence of pulmonary microthrombi, intravascular coagulopathy, myocardial injury, and an elevation of cardiac biomarkers, and also, importantly, very elevated D-dimers. There's classic evidence of macrovessel thromboembolic disease, such as venous thromboembolism, myocardial infarction, and stroke. And only a minority of patients, about 10 to 15%, have been described with classic disseminated intravascular coagulation. Thus, antithrombotic strategies for decreasing this coagulopathy can be looked at in terms of being multifactorial in nature. One can retard entry of the virus into the endothelial cell. Of course, targeting virus-induced inflammatory responses may be beneficial, and we've seen now clear evidence of the benefit of using generalized anti-inflammatory agents such as corticosteroids, especially in severely ill hospitalized COVID-19 patients, but other more specific strategies such as the potential to target IL-6 receptors or to target complement activators. Antiplatelet agents also remain, I think, viable with respect to antithrombotic strategies. Of course, the logical step is to target various procoagulant factors, especially factor Xa and thrombin. But one can also consider more novel inhibition of the coagulation cascade, such as contact pathway inhibitors, especially factor 11A inhibitors, as potential targets. One can also enhance fibrinolysis, as well as enhance the body's natural anticoagulation pathways, either with antithrombin-dependent mechanisms such as unfractured heparin, low-molecular heparin, and fondaparinux, but more novel approaches such as targeting activated protein C or thrombomodulin. Now, we now have a good sense of what are some of the key predictors of thrombosis in hospitalized COVID-19 patients. And these include markers of sepsis, such as elevated sepsis-induced coagulopathy scores, D-dimers, especially greater than 4 times and 6 times the upper limit of normal, and now consistently have shown prognosis for both poor outcomes and an increased risk of thrombosis. And classic clinical risk factors such as advanced age, obesity, and underlying cardiovascular morbidity also portend an increased risk of thrombotic complications. Finally, ICU stay with mechanical ventilation identifies a very high thrombotic risk patient group. Now, very early on in the pandemic, multiple research groups, including ours, have described certain unique mechanisms of COVID coagulopathy, really leading to a perfect storm involving the inflammatory system, the immune system, and coagulation system to create a prothrombotic state, which mostly involves venous thromboembolism. Now, one of these unique features of COVID coagulopathy is simply the high prevalence of thrombotic complications, especially in hospitalized and critically ill COVID-19 patients. So early on in the pandemic, deep vein thrombosis or DVT rates as much as 46% to as high as 85% have been described in these earlier smaller case series. Subsequent larger cohorts, especially New York City area hospitals, have described much lower rates of VTE and DVT in the 5 to 6% range, especially in medical wards, suggesting that these earlier reports suffered from either ascertainment bias and probably overestimation of risk. However, when one looks at the rates of pulmonary embolism that have been described as high as 42%, which are less subject to bias, one sees an overall threefold higher risk compared to historical matched controls. Lastly, rates of arterial thromboembolism approaching 4% have also been described in this patient population. The second, I think, interesting feature of COVID coagulopathy is simply the unusual nature of thrombosis in these patients. So on the left, we see evidence of in situ pulmonary embolism against a background of ground glass appearance seen in severe COVID pneumonia. And on the right, we see evidence of pulmonary microthrombi with fibrin deposition seen in blue, and also megakaryocytic deposition as well. But perhaps the most striking nature of COVID-19 coagulopathy is this phenomenon of breakthrough thrombosis despite standard thromboprophylaxis. So that despite standard thromboprophylaxis with either unfractured heparin or low liquid heparin, especially in ICU settings, confirmed VTE rates as high as 27% have been described. And despite prophylactic or even higher dose anticoagulant therapy, thrombotic complication rates approaching 17% have been described in ARDS patients, which represent nearly a 6-fold higher rate of thrombotic complications compared to non-COVID ARDS patients. And at least in one small study using systematic screening in ICU patients, despite standard dose prophylactic agents, a VT prevalence of 100% has been described. Now, because of these worrisome features of COVID coagulopathy, multiple both US and international antithrombotic guideline and guidance documents by multiple groups early on described the need for thromboprophylaxis in this patient population. So that the CHEST guidelines in both non-critically ill as well as critically ill hospitalized COVID-19 patients suggested routine use of parenteral thromboprophylaxis, again with a preference of low liquid heparin over other agents due to more limited drug-drug interactions and to limit staph exposure in these patient populations. These guidelines recommended against routine use of antiplatelet agents and recommended using standard prophylactic doses of thromboprophylaxis. After hospital discharge, these guidelines recommended against the use of routine extended thromboprophylaxis. The International Society of Thrombosis and Hemostasis guidelines, or ISTH guidelines, which I was privileged enough to chair, also have very similar recommendations for both non-critically ill as well as critically ill hospitalized COVID-19 patients. We advocated for the use of standard prophylactic doses of parenteral thromboprophylaxis with LMWH as the preferred agent, again, because of decreased potential for exposure, as well as more predictable pharmacokinetic profiles and less drug-drug interactions compared to other agents. We recommended, again, the standard prophylactic doses in hospitalized ward patients, but in critically ill patients, we left open the possibility of using higher than usual doses, namely intermediate doses, in high-risk patient subgroups, especially those who were critically ill and who were obese. And after hospital discharge, we did advocate for the use of extended post-discharge thromboprophylaxis for hospitalized COVID-19 patients that met high VTE risk criteria with either LMWH or preferably a direct oral anticoagulant for up to 30 days after discharge. So this slide represents a summary of both United States and international guidance documents on how we manage VT prevention as well as treatment in hospitalized COVID-19 patients. As we see, all of the various groups, including the ACC, ASH, CHEST, ISTH, NIH, and WHO, recommended universal use of prophylactic dose parenteral therapy, again, mostly with preference for low liquid heparin. For ICU patients, this was similar, except as I mentioned, our guidance documents also advocated for the potential for using intermediate dose heparin in high-risk patients, especially those who were obese in the ICU. And at least some of the guidance documents, again, advocated for the use of post-discharge thromboprophylaxis in high VTE risk patient groups. For VTE treatment in patients with confirmed VTE, most of the guidance documents advocated for therapeutic parenteral antithrombotic and anticoagulant therapy with a 3-month length of therapy. Now, this slide here represents our VT prophylaxis guideline at Northwell Health, which is a very large 23-hospital health system around the New York area. And very early on in the pandemic in the United States, our health system had approximately 1/4 of all hospitalized COVID-19 patients seen in the United States. Very early on, we adopted a very aggressive and universal thromboprophylactic policy for these patients, both in the ICU as well as non-ICU settings, advocating for a lower than usual creatinine clearance to dose the preferable agent, which is an enoxaparin 40 milligrams sub-Q daily. Also, for patients with a BMI greater than 30, we advocated for the use of intermediate dose enoxaparin at 40 milligrams sub-Q BID. Both of those strategies aim to increase the level of heparin exposure in patients, thus potentially protecting them from thromboembolic complications. But I think the most important clinical question to be asked and answered in hospitalized COVID-19 patients is this: is exposure to escalated or treatment dose anticoagulant therapy, does it have potential to decrease coagulopathy seen in COVID-19? So early on, there was some case series to suggest that low liquid heparin users versus heparin non-users conferred a mortality advantage at 28 days, especially in those patients with very elevated D-dimers or SIC scores, as we see here evidence of an approximate 40% reduction in mortality. In addition, there was early evidence to suggest that the use of empiric therapeutic dose anticoagulants may reduce hospital-based thromboembolic complications by about 70% or so. Towards this end, there are now up to 20 high-quality randomized trials globally of escalated or treatment dose anticoagulants versus standard of care heparin in hospitalized COVID-19 patients. And these include the large multi-platform trials, including the ATTACK, REMAP-CAP, and NIH Active-4 trials, as well as the moderate-sized trials such as the HEP-COVID trial that we're conducting in the United States. As we see here, the vast majority of study designs are open-label and multi-center clinical trials that are randomized. Populations include both ICU as well as non-ICU patients. The interventions, for the most part, include the use of therapeutic dose low liquid heparin or unfractured heparin, with a control group being standard of care heparin based on local hospital practices. The primary outcome of these trials include either all-cause mortality or combinations of all-cause mortality and major thromboembolic events, or a combination of both, including also freedom from organ-free support. Now, there was one small published trial out of Brazil that suggested advantages of therapeutic versus prophylactic anticoagulation, especially in severe COVID-19 patients. Patients randomized to therapeutic and enoxaparin appeared to have a decreased number of ventilator-free days, as well as improved oxygenation parameters. Also importantly, in the last month, there have been two at least conflicting reports from the large multi-platform trials with respect to study activities. On December 22nd, 2020, the multi-platform trial DSMB paused enrollment in the ICU or severe COVID-19 patient population due to safety concerns and potential lack of efficacy of therapeutic anticoagulation in reducing the primary outcome. More recently, on January 22nd, 2021, the same DSMB groups showed the opposite statement with respect to the potential for improved efficacy and need for organ support, and possibly a mortality advantage with therapeutic anticoagulants in the moderate or non-ICU patient population. The results of these trials are eagerly anticipated pending publication in a peer-reviewed journal. The other aspects with respect to work of VTE risk in hospitalized COVID-19 patients is the potential to use validated VTE risk scores to stratify patients into low, moderate, and high VTE risk categories. And in this large validation study of over 9,400 patients that we undertook in our health system, we saw that using the validated improved score with the addition of the elevated D-dimer as a relatively novel biomarker was able to identify patients hospitalized with COVID-19 into three categories: low risk, moderate risk, and high risk, with the VT rates of about 0.4% in the low risk categories, 1.3% or so in the moderate risk categories, and 5.3% or so in the high risk categories. Importantly, about 50% of patients were at high VTE risk, but a full 20% of patients were in the low risk category, suggesting that a universal policy of thromboprophylaxis may cause harm in these low risk patient populations. The other aspect of COVID coagulopathy that deserves mention is in the post-hospital discharge setting. Earlier reports that were retrospective and usually small in design, suggested a very low rate of thromboembolic complications in the post-hospital discharge period. But recently, we presented a very large prospective registry, the CORE-19 registry that we conducted in our large health system, which represented complete follow-up in over 4,900 patients. As in our protocol that I'll share forthwith, we advocated for the use of post-discharge prophylaxis, preferably with a direct oral anticoagulant such as rivaroxaban, for patients with high-risk features. We found with our large prospective registry a higher than anticipated rate of thrombosis, with an overall VTE rate of about 1.55%, with half of the events being PE, an arterial thromboembolic event rate of 1.71%, an all-cause mortality rate approaching 5%, a higher than anticipated major bleeding rate of 1.7%, and a rehospitalization rate of 15%. Importantly, in a multivariate analysis, post-discharge extended thromboprophylaxis decreased thrombosis and all-cause mortality by 46%, suggesting that a strategy of post-hospital discharge extended thromboprophylaxis may be beneficial in high VTE risk patient groups. And this represents, again, our extended VTE prophylaxis protocol that we initiated very early on during the early phases of the pandemic, systematically in our 23 hospital system. For those patients who had high VTE risk factors defined by an improved score of 4 or more, or advanced age and elevated D-dimers, we advocated for the use of either enoxaparin, 40 milligrams, or preferably rivaroxaban, 10 milligrams for up to 30 days post-hospital discharge. as long as patients, of course, did not have high bleed risk factors. The last thing that I want to mention is there a potential role for primary thromboprophylaxis in patients in the pre-hospital setting with COVID, especially those patients with underlying cardiovascular risk factors. And to answer this important question, there are at least 3 large outpatient trials: the OVID trial, the NIH COVID trial with apixaban, aspirin, and the PREVENT HD trial that we're undertaking in the United States. Again, the NIH and PREVENT HD trials are large trials of 7,000 patients and 4,000 patients respectively. And we see here in this slide the study design of the PREVENT HD trial, where we are randomizing patients with a diagnosis of COVID within 14 days and at least one cardiovascular risk factor, randomizing them into either receiving placebo or rivaroxaban 10 milligrams daily for up to 35 days. And we're seeing if this strategy reduces a composite outcome of VTE, ATE, all-cause mortality, and hospitalization. So, towards the end of this discussion, I think it's important for all of us to conceptualize 3 periods of thrombotic risk for COVID-19 patients: the outpatient period, which we think represents a low-risk period, but potentially patients with diagnosis of COVID and underlying cardiovascular disease may be at increased risk. And here, the key question is there benefit for using a primary prevention strategy, preferably with a low-dose DOAC? The second period is the hospitalization period, which we know represents a high thrombotic risk period, in which all of the both U.S. and international guidance documents advocate for the use of universal thromboprophylaxis with either standard to intermediate dose low liquid heparin or unfractionated heparin. However, pending the results of the large ongoing randomized trials, this recommendation may change. Also, I think the key question here is there a subset of hospitalized COVID-19 patients that are at low VT risk and may not benefit from a strategy of universal thromboprophylaxis. And lastly, in the post-hospital discharge period, which we think represents an intermediate thrombotic risk period, is there benefit of extended thromboprophylaxis, especially with a DOAC, for up to 30 days in high-risk groups. So to conclude, future antithrombotic strategies in COVID-19 disease really run the spectrum and the gamut of the patient journey, all the way from the healthy outpatient with no underlying cardiovascular risk factors to the symptomatic outpatient with cardiovascular risk factors. And here, as we said, the key question is there benefit of using a DOAC or even a combination of DOAC or aspirin alone as a potential antithrombotic strategy? We know that hospitalized COVID-19 patients are at elevated risk of thrombosis and that medical ward patients should, for the most part, receive standard thromboprophylaxis at this point, although this can change with respect to the guidelines in the near future. The critically ill patient with COVID-19 represents a special subtype at very high risk of thrombosis. And here there are a very myriad number of strategies being looked at present, including not just the use of standard thromboprophylaxis or escalated dose thromboprophylaxis, but other novel strategies such as use of fibrinolytic therapy, danaproid, antithrombin, thrombomodulin, activated protein C, and others such as tissue factor and factor 7A inhibitors. And lastly, in the post-hospital discharge period, the key question is there benefit of post-discharge thromboprophylaxis, preferably with a DOAC, especially in high-risk groups? With this, I thank you for your attention.
This is Benoot Bikhteli. I'm a cardiologist and a vascular medicine advanced fellow from Division of Cardiovascular Medicine at Brigham and Women's Hospital, Harvard Medical School. Also, I have affiliations with Center for Outcomes Research and Evaluation at Yale University and the Cardiovascular Research Foundation. Here are my disclosures, none of which are related to this talk. What I'm going to talk about is a few things. First, discussing the factors associated with risk of thrombosis in patients with COVID-19, and also incidence rates of venous thromboembolism in critically ill patients with COVID-19 and other subgroups, and then discussing prophylactic options in these patients, as well as management issues for short-term and long-term. And all of these are going to be discussed in the context of a couple of challenging cases. So case one, it's a 62-year-old lady with history of obesity and asthma, gets admitted to the ICU with COVID-19 associated respiratory failure, has had one prior hospitalization since last year, nothing else. And the question is, what is the best antithrombotic prophylactic regimen for this patient? So it's somebody who is very sick, COVID-19, ARDS, pneumonia, and also history of asthma and obesity. How do we mitigate the risk of thrombosis? So the first question is COVID-19 really a prothrombotic state? And there have been a series of studies and review papers that have suggested that COVID-19, in addition to the pulmonary findings that you can see on the left-hand side, is also an endothelial disease, meaning that the virus through the ACE2 would be able to enter endothelial cells, and through a whole host of mechanisms shown on the right-hand side in part, might lead into a procoagulant state. In addition, there could be multiple risk factors for thrombosis that are common in patients who are afflicted with severe COVID-19, not to mention that we also have an element of stasis because the patients are sick and in bed. So first element is stasis, second is a hypercoagulable state, and then we also have endothelial activation. So it's the perfect storm for the Virchow's triad. So in the setting of all the mechanisms that I was discussing, this classic paper by Eric Klock has been referred to multiple times since the initial days of the pandemic, where the authors reported north of 30% cumulative incidence event rates for thrombotic events. And this was replicated in a study by Dr. Piazza and colleagues from Boston that also showed in critically ill patients, over 35% of patients had the incidence of venous or arterial major thrombotic events. So from one perspective, we can say that thrombotic events are very common in patients with COVID-19. But also there is the other perspective. Some others, including the study that I'm showing, a multi-center study on the left-hand side, published in Blood, they suggested that only 4.8% of patients with COVID-19 who were hospitalized are suffering from venous thromboembolic events, including less than 8% among critically ill patients. And then the American Heart Association launched a registry, again, multi-center, which showed that venous thromboembolic events, including deep vein thrombosis and pulmonary embolism, were relatively rare, each of them less than 3% and even combined less than 5% in hospitalized patients. So the real question becomes, what is the true incidence rate? And part of it was addressed by a systematic review and meta-analysis of the published literature that I'm showing to you on that left-hand side. As you can see, there is so much heterogeneity, but suffice it to say that the pooled incidence is close to 17% with wide 95% confidence interval estimates. But it's important to note that as many as 28% of hospitalized ICU patients with COVID-19 had VTE. The one trick that, again, we will be talking about to some extent is many of those events were either isolated deep vein thrombosis or subsegmental pulmonary emboli that some people think might not even be embolic and might be related to the so-called immunothrombosis phenomenon. But in any case, we see that the systematic pooled incidence is close to 28%, indicative of high risk of thrombotic events in these patients. So really, we're going to have three separate options. Option one is to use low-dose prophylactic anticoagulation. Then we have the middle option of intermediate dose, such as enoxaparin 1 milligram per kg per day. And third is to go just fully therapeutic dose anticoagulation just for the empiric purposes because we are so scared. For example, many of these patients have D-dimer levels higher than the assay can detect. So out of these three options, I wish we had a crystal ball to pick which one is best, but we don't. So the best that we can do is to enroll patients in randomized trials. And in that spirit, the first study that came out as a randomized study was Histopathology trial. That was a small single center study from Brazil, nearly 20 patients with severe COVID-19 mechanically ventilated, who were randomized to standard prophylaxis versus therapeutic dose anticoagulation without known evidence of thrombosis. And the primary outcome, which was P to F ratio, meaning PaO2 divided by FiO2, showed that there was some improvement with increased intensity anticoagulation. And even when they were trying to look at successful weaning from mechanical ventilation, again, they saw a trend toward improvement for people who received therapeutic dose anticoagulation. So far, so good. But the challenge is this was a study of only 20 patients, so so much prone to type 1, but also type 2 error. So this was followed by a news release from the National Institute of Health, where they reported that 3 studies that were being followed concomitantly, active 4, in addition to REMAP, CAP, and ATTACK, halted enrollment of patients in critically ill subset who were randomized to standard dose prophylaxis versus therapeutic dose prophylaxis with heparin-based regimens because there was a concern for futility. So in this context, we know from preliminary reports that apparently full dose prophylactic anticoagulation is not conferring benefit, but all of us await further clarifications from the NIH and also the 2 other large-scale trials that were conducted and followed by the data safety and monitoring boards. Inspiration is a study that I've been involved with, and I've been honored to work with and learn from many other investigators in the process. It's essentially trying to answer the question whether in critically ill patients with COVID-19, use of an intermediate dose regimen, predominantly enoxaparin 1 milligram per kg once a day, compared with standard prophylactic anticoagulation, has the capacity to improve clinical outcomes in critically ill patients with RT-PCR confirmed COVID-19. The study primary endpoint is a composite of all-cause mortality or venous or arterial thromboembolic events. And the study is gonna be powered to detect a 12% absolute risk reduction in the primary endpoint event rate, for which it required 600 patients to be enrolled. I'm glad to say that we have completed the enrollment, and as we speak, we are finalizing the analyses for the primary endpoint of inspiration, so the results should be out very soon. But until then, back to case 1, our 62-year-old lady with obesity, asthma, and critically ill COVID-19. How do we mitigate the risk? In my humble opinion, based off of preliminary reports from the NIH, fully therapeutic dose empiric anticoagulation should not be given. Do we give intermediate dose anticoagulation or standard prophylaxis or other agents? I think it's really an open question, and the consensus documents have given very mixed set of recommendations. In my humble mind, for the moment, perhaps the best thing to do would be to consider enrolling the patient in a randomized trial so that what we're doing today would be able to inform us for future practice as well. Moving to case 2, it's a 45-year-old gentleman with history of type 2 diabetes who was hospitalized for COVID-19, and in the process of hospitalization, the patient has developed an acute thrombotic event. Did not have a history of venous thromboembolic disease in the past. The question is, what dose of anticoagulation to use? Should we use regular dose, high dose, and how do we administer? So first, going back to the guidelines that we have from European Society of Cardiology, we know that infection, including pneumonia, is a major risk factor for venous thromboembolic disease. But the question is COVID-19 really just an acute medical illness? Is it just a pneumonia, or there is something beyond that? And it's important also to factor in the severity of venous thromboembolic disease on the left-hand side compared with the severity of potential complications on the right-hand side of this panel. So we can think of subsegmental PE or just a proximal DVT or lobar and segmental PEs, all the way up to PE-related mortality, which comes from hemodynamically significant pulmonary embolism. And even when we're thinking about the potential complications, there could be nuisance bleed without clinical consequences, all the way up to intracranial hemorrhage or even fatal bleeding events. when we want to treat these patients, another important issue is how do we try to optimize care based off of various factors, being costs, drug-drug interactions, and others. If we want to consider unfractionated heparin, the good thing is its efficacy as monotherapy has been shown. It's fairly cheap. It does not have a ton of drug-drug interactions. However, there are two concerns. Number one, it needs a lot of monitoring, and for that reason, it's going to expose the healthcare workers to the patient again and again, more contact. This is not something that we commonly thought about in pre-COVID days, but here it becomes a concern. Low molecular weight heparins are a fascinating option without any concerns. To some extent, direct throm inhibitors are also favorable, but again, they're very costly. They need monitoring, and by the same token, they require healthcare worker exposure. Direct oral anticoagulants could be also an interesting option, but again, the concerns are twofold. Number one is the cost, and number two, as I will get to later, here we might have potential drug-drug interactions, and warfarin is arguably the least desirable choice in this case. So in essence, what we can see is parenteral agents do not have much of drug-drug interactions. There might be other trade-offs though. And this is a graphical summary of more of the same. Here you're seeing some of the commonly used COVID-19 treatments. And the concern is with several of the oral antiplatelet agents or oral anticoagulants, there might be potential interactions. So if I were to summarize it, these are things that we need to consider ultimately when we want to treat. And when we look at the COVID-19 treatment guidelines by the National Institutes of Health, they're also recommending that patients who require treatment should be managed with therapeutic doses of anticoagulant therapy. And on the right-hand side is the consensus document that we prepared along with 5 major societies, including NATF, wherein we recommended that the treatment should be used similar to patients outside of the COVID-19 context. But because of the reasons we went over, the initial treatment would be reasonable to be done with low molecular weight heparins. So back to case 2, we had this 45-year-old gentleman with history of diabetes who developed venous thromboembolic disease during a hospitalization for COVID-19 without a prior history of DVT. And the question was what to do in terms of anticoagulation. The short answer could be parenteral anticoagulation while the patient is ill and inpatient, ideally with low molecular weight heparins, and then we can move on and probably switch to a direct oral anticoagulant once the patient gets discharged. The third of the cases is a 50-year-old who's been referred for a clinic visit after having suffered a pulmonary embolism during a hospitalization with COVID-19. Now, the major question is, would there be a lot of risk for recurrent venous thromboembolic disease should the patient be remaining on lifelong anticoagulation or not? Again, as we went over before, COVID-19, like other pneumoniae, might be associated with increased risk of recurrences and venous thrombosis. But the question is there anything above and beyond the regular pneumonia? And the interesting answer comes from a small but fascinating study in Circulation from a few months ago, where the authors compared 2 groups of people. Group 1 was people who had influenza, and group 2 was people who had COVID-19, not just influenza pneumonia. And they saw that COVID-19 was associated with an increased risk of PE. The study, however, doesn't tell us much about the risk of recurrences. So as far as the duration of treatment is concerned, before COVID-19 came, we had the HER2 score, which gave us a numeric score with higher scores suggesting an elevated risk. But there are 2 concerns here. Number 1, this is a male patient, and HER2 was never validated for male patients. And number 2, this is a case where we are not entirely sure whether or not we can call it unprovoked VTE. And last but certainly not least, HER2 was not validated in the setting of COVID-19, so we cannot use it. Secondly, the DASH score is also available, but also the same issues exist. It was studied for patients with unprovoked VTE and not during the COVID-19 era. So unfortunately, these 2 scores do not tell us much. And COVID-19 specific data do not exist for the moment. but we remain very hopeful that generating additional knowledge based off of RIATE registry and also coronal VTE registry, among others, would be able to help us make informed decisions for patients for how long the duration of anticoagulation for these patients should be. What I want to point out again is, to some extent, we need to think of the index event. Was it a severe event or not so severe event? And secondly, what are the risk factors for bleeding? How prone is the patient to a major bleeding event? That plays into duration of anticoagulation like any other patient. So going back to our case, it was a 50-year-old who was referred to clinic after having suffered a pulmonary embolism during the prior hospitalization for COVID-19. Duration of anticoagulation, I think it's going to be standard treatment at least for 3 months. But the key question is for how long further we are going to track it. Maybe it's reasonable to check inflammatory markers, including also D-dimer at 3-month follow-up to see if still there is a procoagulant milieu and a hyperinflammatory state. And rest of it really should be shared decision-making in terms of benefits versus risks and harms of anticoagulation until further data would be able to guide our practice. So in conclusion, COVID-19 may indeed be a prothrombotic state, and for critically ill patients with COVID-19, for the moment, it's advisable not to empirically use fully therapeutic anticoagulation. Enrollment in randomized trials for other agents might be reasonable until we have further clarifications. Results of INSPIRATION are expected to come out very soon. And parenteral anticoagulations really should be the cornerstone of treatment for patients with incident thrombotic events in COVID-19 cohorts. They do not have major drug-drug interactions. And once the patients get discharged, DOACs could be a reasonable choice. The optimal duration of treatment after a venous thromboembolic event after COVID-19, however, remains a mystery, and I hope that future studies would help guide us all. Thank you very much for your attention.
Thank you so much for your interest in this program. We truly value your feedback, and a short survey will be emailed to you to complete after the program. A recording of this event will also be posted on NATF's COVID-19 Provider Resources webpage on February 19th, 2021. If you have any questions, concerns, or suggestions pertaining to this program, please contact us at events@natfonline.org. Thank you again for your time and attention.